I told you on Friday when we talked about dislocations that both sprains and dislocations are articular trauma. But the big difference between these two is the fact that sprains are usually not accompanied by X-ray changings. In other words, if we take an X-ray of the joint that had a sprain, probably we'll find a normal X-ray. And also, I was telling you that sprains are very peculiar for the joints of the lower limb because they have a very strong articular capsule and ligaments, and that's why they usually don't get dislocations but only sprains. Okay, theoretically, any joint from our body may get a sprain, but by far there are some joints that are, let's say, first candidates to get a sprain. And the most frequent sprains in our body are in the ankle joint. Let's take some anatomy about the ankle joint in order to understand the mechanism of sprain. If you remember again from anatomy, the ankle is a joint which is between the distal epiphysis of the tibia and the distal epiphysis of the fibula, and the proximal talar bone, which is the talus. So you can see here, these two bones, like the tibia and the fibula, form a sort of reversed U-shaped bone end. So these two together, they have the medial malleolus. Here we see the medial part of the tibia, and the distal epiphysis of the fibula is called the lateral or the fibular malleolus. And in between them, there is the distal part of the epiphysis of the tibia, which is considered the roof of the ankle joint. And so these two bones get into contact with, as said, with the trochlea of the talus. You can see on this picture here that the trochlea of the talus has not the same size at its posterior part and at its anterior part. In other words, it's wider at the anterior part and smaller, narrower at the posterior part. That means that depending of that part of the trochlea which is in the joint, the proximal part of the joint, meaning the fibula and the tibia, must adapt all the time to the size of that part of the talus which is in the joint at that moment. So we understand from this that in order to function normally, the ankle must be ensured by a functional tibiofibular joints. You know that we have two tibiofibular joints, one proximal here and one distal here. And there is, you also know this from anatomy and biomechanics, you know that there is a slight motion between these two bones. So axial movement of these two bones, meaning that the fibula will rotate slightly around the tibia, and that means that all the time the size, the width of the tibiofibular part is adapting to that size of the talus which is at that moment in the joint. So the functionality of these two small tibiofibular joints is very important, because otherwise, if they will be fixed, then when the patient, or let's say, the person will try to put his foot in flexion, then the ankle will become unstable. Here we see again the range of motion of this joint. The ankle joint is a joint with mobility in only one plane, meaning the sagittal plane. So the ankle has only flexion and extension. And we can see here that the degree of flexion is about 50 degrees, and the degree of extension is about 20 to 40 degrees. Well, that depends very much on the uh, of the training of the person, and depends on sex, of course, because in women the ligaments are more elastic. So in women the ligaments have a higher percentage of elastic tissue. That's why the range of motion of their joints is higher than in men. So again, probably I've told you this many times, always we must examine a joint after we examine the counterlateral healthy joint, because some people, like I said, especially young women, have a physiological high degree of motion, which may, let's say, uh, put us in confusion when we examine a damaged joint. Okay, here is again what I told you before. So the size of the trochlea, which is different on the anterior part and at the posterior part. Of course, the joint is the bone ends are kept in place by the articular capsule and the ligaments. And here is a drawing which shows you these ligaments. On the medial aspect of the ankle, the drawing A, we can see the medial collateral ligament. In fact, the ligament on the medial side is named, generally speaking, the medial collateral ligament, and the other one on the lateral side is called the lateral collateral ligament. Let's get into some more details. The medial collateral ligament is also called the deltoid ligament. You know, the letter delta in Greek has the shape of a triangle. That's why in comparison with a triangle, this ligament is called deltoid ligament, because it has a tip at the level of the medial malleolus, where all the fascicles of this ligament start from, and then they spread downwards to different parts of the talus, uh, displaying a triangle shape. That's why it's called a deltoid ligament. We'll see this ligament is very powerful, sometimes, especially in old people who may have a degree of osteoporosis, the ligament may be stronger even than the bone. And on the lateral aspect, we have the lateral collateral ligament, which is composed of three main fascicles. So it has two horizontal fascicles, which is the anterior talofibular ligament, this one here, which prevents the foot from sliding towards anterior. The posterior talofibular ligament, which prevents the ankle or the talus to displace posteriorly. And finally, a vertical component, which is the calcaneofibular ligament, which opposes to the varus position. So in other words, this aspect, this displacement of these components, ligamental components, stabilize the angle in all directions. Of course, in addition, we have the lateral or the fibular malleolus, which is descending more distally than the medial malleolus. So together, the lateral malleolus and these ligament components stabilize the ankle against displacements. What happens? How can we get a sprain? Well, generally speaking, not only about the ankle, but generally speaking about sprains, such a trauma occurs in two main situations. One of them is that when the joint is forced over the limits of its normal range of motion. For example, the ankle, coming back to the ankle is a joint, I said, with flexion and extension. The flexion, when we force the flexion, for example, the patient grabs, let's say, a stair on his anterior part of the foot, and then forces the ankle in forced flexion over the physiological limits. This is one example. Or, of course, the second situation is that one when the joint is forced in a position in which it doesn't normally have any range of motion. And also coming back to the ankle, that will be, of course, like you can see here in this drawing, for example, forcing the ankle in a varus position. Normally, the ankle doesn't have varus or valgus movements. So it may be forced in a, that's the, the, the most frequent mechanism, like forcing the ankle in a varus position. Um, in this position, we may get a sprain, which means a lesion of the lateral collateral ligament, like we can see here, or a fracture of the lateral malleolus. That depends very much on the associated position of the ankle at the time of the trauma, and of course the strength of the bone. I've already mentioned you about osteoporosis. From the anatomical clinical point of view, the sprains may be classified in three types. The first type, or group one, someone's named this like group one, but the same thing is calling them type one, are those sprains when there is not a macroscopical lesion of the ligament. If we look only to the ligament, then macroscopically probably we cannot detect any changes. But if we take that ligament and check his mechanical strength, we'll see that that is decreased at a certain percentage. That means that some fibers inside the ligament have been torn with the occasion of the sprain. So, in fact, this type of sprain, which is the slightest from the clinical point of view, results only in a diminishing of the mechanical resistance of that ligament. Type 2 or group 2 is a partial macroscopical lesion of the ligament. So if we inspect surgically, for example, the ligament at that moment, we can see with our eye, without any magnification, we can see lesion of partial lesion of the ligament, lesion of its structure. So it may be we can even appreciate that in our description by percentage. So we can see that the ligament was torn 50% of its structure, 30%, 70, so on. That's a description which helps us in order to indicate the appropriate method of treatment. And finally, it's the grade 3 or type 3, which is a complete lesion of the ligament. Well, usually after a complete lesion of the ligament or complete lesion of ligaments, because the sprain can affect more than one ligament, then after this type 3 lesion, probably if the trauma continues, there is only one step towards dislocation. How can we diagnose an ankle sprain? First of all, we need to find out about the history of the trauma. If the patient can describe the mechanism, I mean the position of the foot of the time of the trauma, or let's say the circumstances in which the trauma happened, then we may detect from the very beginning which parts of the ligaments are suspected to be torn. Because, you know, if the patient describes a varus position, then of course we think immediately to the lateral collateral ligament. If the trauma was in varus but associated with forced flexion of the ankle, then we may suspect that the main ligament that is torn will be the anterior fibular ligament. You could see in here, it's anterior talofibular ligament in flexion, lateral talocalcaneal ligament in varus position, or combined these two depending on what degree of flexion was at that time of the trauma. So this is only for orientation, because of course it doesn't make a precise diagnosis. Besides that, the first sign, the most important signs or symptoms with the patient comes at the emergency room. The first and the most important is pain. I don't know which one of you had ever had a sprain of the ankle, but the pain which comes immediately after the trauma is very intense and is localized, is located usually on the lateral aspect of the ankle, because the highest percentage of sprains are on the lateral aspect of the ankle. That pain evolves in 3 stages. At the very beginning, immediately after trauma, we have the so-called acute pain, which is, like I said, very intense pain. Is compared with, I mean, it's included in the category of the most 10 intense pains in our body. But this intense pain lasts for about, let's say, 15 to 20 minutes. And surprisingly, without administering any medication to the patient, this acute pain will diminish after that period of time and will lead to a so-called sedated pain, which is a slight pain, much less intense than the first one, which may last about 3 hours. Well, what's the explanation of this phenomena? Because, like I said, we didn't administrate any medication to the patient. That's because you remember again from physiology this time that transmitting the pain is done by synapses. At the level of the synapses, we have the chemical mediators which are responsible for the transmitting of the pain at the level of the synapses. Well, these chemical mediators will be consumed at a higher rate than produced. I mean, the synthesis of these mediators doesn't keep pace with the consumption. So at a certain moment, it's not happening that the pain, I mean, the cause of the pain has gone away. The problem is that the pain cannot be transmitted anymore to the central nervous system due to this disproportion between consuming and synthesis of the chemical mediators in the synapses. It's exactly like you would have been administrating to the patient a local anesthesia. The phenomena, the physiopathological phenomena, is more or less the same. But after 3 hours, when the balance between synthesis and consumption of the mediators will be equilibrated again, then the pain will come back, but not at the same intensity like it was immediately after the trauma. It's a so-called chronic pain, which has an intensity somewhere in between the acute pain and the sedated pain. The other sign is the physical disability, which is very variable depending on the patient. By the way, the pain is also very variable depending on the individual sensitivity of the patient. So you cannot appreciate very objective this pain because, like I said, depends from person to person. And physical disability is of the same manner. Anyway, the physical disability is mainly due to the pain, because due to the patient will be unable to move his ankle or will be unable to set weight bearing on the foot. So these are the signs of physical disability, which may be also variable from patient to patient. The ankle is usually speaking swelled, so we go now to the physical examination. At simple inspection, we may see that in comparison with the counterlateral ankle, on the lateral aspect of the ankle, we have a prominent swelling. We can see here a prominent swelling, which may even have the aspect of a pigeon egg. That was a description was done by the semiologist. Well, anyway, we don't know how the pigeon egg is. We are not zoologists here, but we must know that there is a prominence at the level of the lateral collateral ligament, which is usually done to a hematoma, which forms there, and to the swelling. By palpation, so the next step of the physical examination will be the palpation. Diagnosis of the ankle sprain is very easy to put by palpation. If, of course, the examiner knows exactly the area where the ligament components are located. So if he knows that anatomy, and we are supposed to know it, if you palpate carefully all the ligament components on the lateral aspect of the ankle, the patient will have a painful reaction at the moment when you press exactly the area where we have the lesion. You can see here with our finger, we can palpate that lesion and the patient will react at the moment when we press it. Also, in sprains, we may get ecchymosis, but in comparison with the ecchymosis after fractures, and I told you already this, the ecchymosis in sprains are quite early. I mean, they can be seen probably after 6 to 8 hours after trauma. Uh, That's due also to the fact that the ankle is located very superficial and the ligaments are located exactly under the skin. So, because you know that the ecchymosis are in relationship with the hematomas that usually form at the level of the ligament lesion. So there is a short way from the ligament lesion towards the skin. So that's why these ecchymosis are quite early. So in other words, if we perform a carefully palpation of the ankle, we may get a quite precise diagnosis. But still, we need to take an X-ray to the patient for two reasons. The first reason is that the most often differential diagnosis we have to do for the sprain is the non-displaced fracture of the lateral malleolus. So these two pathological findings are very easily confounded. That's why we need, first of all, an X-ray in order to eliminate the possibility of a lateral malleolus fracture. So if this doesn't exist, then diagnosis will be a sprain. Other situation when this X-ray is necessary, I told you that in old patients with osteoporosis, the ligaments may be stronger than the bone, which they are attached to. And sometimes in such a sprain, instead of a lesion of the ligament, we may get a small fracture of the bone at the level of the ligament insertion. So that small fragment will be detached from the area by the ligament during the mechanism of sprain. And of course, this small fragment may be detected on the X-ray. This is also very important because it may change completely the treatment. And finally, there are situations when persons, I told you about young women, persons who have very lax joints due to the laxity, or the physiological laxity of their ligaments. And sometimes we may take an X-ray of the normal ankle and then to the injured ankle in order to compare those two and see what level, what's normal and what's pathological in that person. Okay, we have the diagnosis, we have the X-ray. Look here on this X-ray down right. So it's the same ankle. Here is a front view of an ankle in neutral position. And here is the same X-ray, I mean the X-ray of the same ankle in a forced position. What do I mean by forced position? I put the ankle in restoring, following the same mechanism of the sprain. I force the ankle in a varus position, and in this position I will take another front view X-ray. And you see what happens. The ankle opens even widely on its lateral aspect. Here is the mechanism which is done. Well, that was done uh, on the X-ray plate, of course, because and in the old times a person was supposed to be there by putting the ankle in that forced position by wearing a special glove which will prevent the X-rays to touch his hand, and in this position we'll take the X-ray. And so we can find out that there is an angle, we can describe an angle between the ceiling of the joint and the top of the dome of the talus. Usually, the lines that are drawn through these bone ends must be parallel, like you can see here in the normal joint. But when the joint opens, then these two lines can describe an angle. And here in the slide, there is a sort of an algorithm, yeah, depending on the angle that we measure at this level, that may show us how many components of the lateral collateral ligament are involved in the sprain. And you can see here, if it's between 10 and 15 degrees, only the peroneo-astragalian anterior ligament is involved. If it's 20 to 25 degree, the first one together with the peroneo-calcaneus ligament. And then if there is towards 40 degrees, like you can see here, yeah, in this X-ray, probably all the three components of the lateral collateral ligament can be involved. Of course, this fourth position is possible only by putting the patient under anesthesia. Any type of anesthesia like general, regional, epidural, doesn't matter. It's not us who decide the type of anesthesia, but the anesthesiologist. But of course, it's mandatory the patient to be under anesthesia, because otherwise he will not allow you to put his ankle in this fourth position, the same position in which he had the trauma immediately after that, because that will be very painful. So what we done before showed us the stability of the ankle in the frontal plane. But we need to do the same thing in the sagittal plane, because you see, if we grab the leg with one hand and the heel with the other hand, and try to push, in fact to pull the foot anteriorly, we may have the surprise to obtain a so-called anterior drawer. So the foot is lax, the ankle is lax, and allows the foot to come to anterior position. And here is such an X-ray, and in this fourth position, we take an X-ray of the ankle, but this time a lateral view, and we may see a displacement between the talus and the tibia, which can be measured this time in millimeters as a distance. So that distance can make objective the laxity of the ankle in the sagittal plane. And on the right side, you see a special modular device that allows to put joints, generally speaking, in fourth position without being necessary for the surgeon to be there. Because, you know, the X-rays, which are spread all over the room during the X-ray examination, will damage otherwise the medical staff who will keep the ankle in the fourth position. So there is no need nowadays for someone to be there when we expose the joint to the X-rays, because we have such a device which can be, of course, is being modular. It can be modified according to the joint we want to examine. So in conclusion, by doing all these dynamic tests, we can test the stability of the ankle in the frontal plane and in the sagittal plane. What complications may accompany a sprain of the ankle? Well, we may have sometimes, but not very often, neurological complications, meaning damaging of the nerves. And probably the most common among these complications is the temporary palsy of the common fibular nerve. The common fibular nerve, like you know, is a terminal branch of the sciatic nerve and has a very close contact with the neck of the fibula, so with the proximal part of the fibula. When we have a high degree varus position ankle sprain, then it will occur also an elongation of the fibular common nerve that may lead to a temporary palsy. We can check this by inviting the patient to do the extension of the foot on the leg. It is also called the dorsiflexion. So extension or dorsiflexion is the same thing. The patient will not be able to do this movement because, like you know, all the muscles in the anterolateral part of the leg, which are responsible of this movement, are innervated by the fibular common nerve. Other lesions may be like osteochondral lesions. During the tough contact between the dome of the talus and the lateral malleolus, a small fragment, usually from the superolateral angle of the dome of the talus, may be detached. You see here, it's this small red fragment. It may be detached from the talus and become a loose body inside the ankle joint. Well, the consequences of this happening is that, first of all, the joint will be locked, like always when we have a loose body inside the joint. And second, the integrity and the anatomical shape of the dome of the talus will be damaged. And we'll have an incongruence between the tibia and the talus, which may lead in time to osteoarthritis. So, from both reasons, we need to operate the patient in these situations. Uh, and depending on the size of the fragment, do one of the two actions. First of all, I have to say that that small fragment may be osteochondral or only chondral. When it's only chondral, then it won't be visible at the X-ray examination, and we may need to perform an MRI of the ankle. And you see here this groove, meaning that something lacks from there, yeah? Is exactly our fragment which is somewhere in the joint. If the fragment is osteochondral, so big enough, we prefer to put it back in place where it detached from and fix it, usually by with using two small resorbable screws. Resorbable screws in order to avoid a next surgery to remove the osteosynthesis hardware. Of course, that's a very good method and will restore the anatomy of the dome of the talus. If the fragment is small, and usually only chondral fragment, we prefer to remove it at all and in order to unlock the joint, and probably the small size of the fragment will not damage the congruence between the two bones in the joint. By far the most frequent complication of an ankle sprain will be the chronic instability, meaning that after the first sprain, the joint of the patient will become a sort of unstable, or let's say, in other words, not stable enough, in order to allow more and more frequent sprains, and sprains that will happen at a lower and lower energy of the trauma. So that chronic instability is that what we have to treat in many situations after an acute sprain. The differential diagnosis of a sprain on the lateral aspect of the ankle may be done also with the dislocation of the fibular tendons. You know, you remember from anatomy that posterior to the fibular malleolus we have the tendons of the fibular or peroneal, whatever you want to name, muscles. We have mainly the long and the short peroneus muscles, and their tendons, which go attached to some bones of the foot. There you have to remember from anatomy also. Those tendons, they change their directions because they surround the lateral malleolus. They are surrounded by a synovial and fiber uh, um, sleeve, yes, that allows on one side the gliding of the of the tendons, on the other side is keeping them in their position. During a sprain, the sudden contracture of the peroneal muscles may take out these tendons from their fiber sleeve and may locate them anterior to the fibular malleolus. So in fact, it's a dislocation of these tendons. When this occurs, of course, we need to operate the patient in order to put back the tendons and secure them there by suturing the fibrous sleeve. Other differential diagnosis may be done with the subtalar sprain. Well, between the subtalar joint and the ankle joint is a very small distance. To make a precise diagnosis in between these two joints is sometimes impossible to do. Fortunately, the symptoms and the treatment also are the same for ankle and subtalar joint. So we don't are in a too much error if we confound the subtalar sprain with the ankle sprain, because like I said, the patient will take benefit of the same treatment, which we suppose will be the correct one. And finally, I have already told you that the most frequent differential diagnosis must be done with the non-displaced fractures of the lateral malleolus. Of course, this one is done by the X-ray examination. How do we treat the acute ankle sprain? Well, the treatment depends on the type of the sprain. The type 1 sprain, well, like I said, we don't have a macroscopical lesion of the ligament. We can treat it by rest, by anti-inflammatories, painkillers, and refrigeration of the area. So we put an ice pad on the lateral aspect of the ankle and invite the patient to limit his physical activity for a period of about 7 days. If the diagnosis was correct, then after 1 week, probably things will go to normal and the patient will get back to its normal physical activity. In type 2 sprains, then the treatment depends on the result of the dynamic tests. That's exactly what I've told you about with that X-rays in forced position. If the dynamic tests are negative, meaning that the ankle will not open on the lateral aspect over its physiological status, then we can use the so-called strapping. Strapping means that we apply a non-elastic bandage, adhesive, a bandage that sticks to the skin, so an adhesive bandage uh, at the level of the skin around the ankle. This is a sort of U-shaped bandage which comes from the lateral aspect of the distal leg, then goes beneath the heel and mounts on the medial aspect of the leg. It's an U, an adhesive bandage of the shape of U, which, I mean, in the frontal plane, which supports, in fact, both lateral collateral ligaments. And with this strapping, we can allow the patient for the weight bearing, of course, by limiting his physical activity. Of course, we administrate also the painkillers, anti-inflammatories, and refrigeration. If the dynamic tests will show us opening of the ankle of a certain degree, then soft bandages will not probably be enough. And we need to put the ankle in a cast. So we have to immobilize in a short leg cast for about 3 to 4 weeks in order to achieve a very rigid immobilization of the ankle, which will allow the torn part of the ligament to heal. And finally, if we have a third degree sprain, then the only rational treatment will be the surgical treatment, which consists in a suture of the torn ligament by using non-absorbable sutures, followed by the immobilization of the ankle in a cast, of course, for about 3 to 4 weeks, which is a necessary time for our sutures to heal. After we remove the cast, then we start in all situations the physical rehabilitation, which has the goal to strengthen the peroneal muscles, first of all, and then to regain the normal range of motion of the ankle. The same thing that happens on the lateral aspect of the ankle may happen also on the medial aspect. This time, of course, the mechanism of sprain will be reversed. Instead of varus position, we'll have a valgus position, like you can see here in this drawing. So involved in this sprain will be this time the deltoid ligament. By the way, I've told you that the deltoid ligament is very strong, much stronger than the lateral collateral ligament. So very often during this mechanism, instead of a lesion of a deltoid ligament, we may have a fracture of the medial malleolus. Anyway, if we have a lesion of the deltoid ligament, sometimes this ligament will go into the joint and will make impossible uh, healing of this sprain. So if the free end of the ligament after it was detached from the lateral aspect of the calcaneus may go into the joint, and that's why in these situations we need to operate the patient to take out that end of the ligament from the joint and put it back in the place where it's detached from. All the symptoms of this sprain are the same, unless all of them have moved from the lateral aspect of the ankle to the medial aspect of the ankle. Pay attention. I suppose you were told about this when the fractures of the lower limb were presented. We may often have the association between a fracture of the lateral malleolus and a sprain on the medial side. I mean a lesion of the deltoid ligament, which is a very often association and must be taken into consideration when we decide about the treatment. The treatment may be by immobilization, the same thing that happened on the lateral aspect in sprains of degree 1 and 2, and maybe surgical, especially when the ligament is entered the joint in the type 3. Like I said, the most feared complication of the ankle sprain will be the chronic instability. That means that the patient will have sprains very easily. It's necessary only to walk, for example, on a, let's say on a ground which is not flat, and it may get a sprain. I mean, the patient may get a sprain. That's first of all because the lateral collateral ligament doesn't heal properly, so its function of maintenance of the stability doesn't exist anymore. And besides this, the proprioceptive mechanism of the peroneus muscle tendons is also inactive. What does this mean? You know, when an ankle is forced in a varus position, um, what prevents the sprain is, of course, first of all, the mechanical resistance of the lateral collateral ligament. But also the helping mechanism will be the contracture of the peroneal muscles, which have a sudden contraction of the moment of the trauma by helping the stability on the lateral aspect. After many sprains, this reflex mechanism is more or less eroded, so it doesn't function properly. So that's why about 50% of these patients with chronic instability on the lateral aspect may heal only by kinetotherapy, the kinetotherapist having the task to re-educate this proprioceptive mechanism by different methods they have, which are specifically to kinetotherapy. When this mechanism will be brought back, then some almost 50% of the patients will not need any further surgery or something because they will stabilize the ankle by only by this active proprioceptive mechanism. Here is one of the methods which kinetotherapists must use in order to stabilize the ankle. It's a rotating plate, you know. Well, I don't go into details because we are surgeons, not kinetotherapists, but I've shown it to you only to have an idea about what can be done at this point. Well, some patients don't get better even by kinetotherapy. So they still have an unstable ankle. Those must undergo surgery, that one being the only method which can solve the problem. Unfortunately, in an old sprain, you will not be able to find the ligament ends like you have done in an acute sprain in order to suture them because they are resorbed. Sometimes they don't exist anymore. So the only way you can solve this problem is to recreate a new lateral collateral ligament. So to perform what we call ligament plasty. There are several methods that have been described to recreate the lateral collateral ligament. I'll present you only one of them, only to have an example, an idea of what can be done. So this method uses as a graft half of the tendon of the long peroneal muscle. You know, the long peroneal muscle, its tendon is inserted on the base of the fifth metatarsal bone and on the cuboid, like you can see here. So we split the tendon of that muscle into two equal parts. One part remains attached, of course, to the muscle in order to uh, to make the action of this muscle possible again, yeah? But the other half, which will be detached from the muscle, will be introduced through a hole in the lateral malleolus and then brought back to itself and sutured to itself by the so-called lateral anastomosis. You can see here with non-absorbable sutures. So this half peroneal tendon will become the new lateral collateral ligament. Of course, the patient must be immobilized in a splint after the surgery, but after that, he has to go to physical rehabilitation. Okay, let's go to the second joint that may have sprains, which is the knee. Like I said, the most frequent sprains are at the level of the ankle joint, but even if in knees they are not as frequent as in ankles, but not very far from them, the knee being a more complicated joint, then these sprains may have even more important consequences over the function of the lower limb. Let's start again with some knee anatomy. Well, the knee is formed between the distal epiphysis of the femur, represented by the two femoral condyles, a medial one and a lateral one, and the proximal extremity of the tibia, which is called the tibial plateau. The tibial plateau at its turn, has a medial part and a lateral part. So besides these two bones, we have also the patella, which is developed in the depth of the extensor mechanism of the knee and which uh, is responsible, which helps the gliding of the extensor mechanism over the anterior aspect of the femoral condyles during flexion and extension of the knee. So in other words, and for our surgical purposes, we prefer to say that the knee joint has three compartments. Pay attention, from the anatomical point of view, we have only one joint cavity. So the cavity of the knee joint is unique. There are no three joint cavities. We, we talk about three compartments in terms of the function of the knee, not in terms of the anatomy. And so we can determine the medial compartment, which is between the medial femoral condyle and the medial hemiplateau, the lateral compartment, which is between the lateral femoral condyle and the lateral hemiplateau, and of course, we have the femoropatellar joint, or compartment, not joint, but compartment, which is between the anterior aspect of the femoral condyles and the patella. Which are the ligaments responsible of the stability of the knee? First of all, we have two collateral ligaments, which are responsible of the stability of the knee in the frontal plane. So we have the medial collateral ligament, which prevents the knee to displace in a valgus position. And we have the lateral collateral ligament, which prevents the knee to displace in varus position. We must also notice that the lateral attachment of the lateral collateral ligament is not on the tibia, but on the head of the fibula. We'll see that is quite important when we'll try to restore the integrity of these ligaments. So the knee, in other words, cannot displace in the lateral plane, not in valgus nor in varus. Beside this ligament, we have the cruciate ligaments, two cruciate ligaments. One is anterolateral ligament, and the other one is posteromedial ligament. This one is anterolateral ligament, and the other one, which is behind the first one, is posteromedial ligament. We usually name them only as anterior cruciate ligament and posterior cruciate ligament. These two ligaments, which are located in the middle of the knee, but inside, of course, the articular cavity, are responsible for the stability of the knee in the sagittal plane. In other words, the anterior cruciate ligament will prevent the tibia from displacing anteriorly, and the posterior cruciate ligament will prevent the tibia from displacing posteriorly. So, with these ligaments, the collaterals and the cruciates, then the knee is stabilized in all directions. In fact, the knee is a joint with only one range of motion, flexion and extension. It has a flexion of about 120, 30 maybe degrees, yes? And the flexion is accompanied by a slight internal rotation of the joint because the two femoral condyles are not equal in size. What's more to be said about the anatomy of the knee? Inside the knee we have two menisci. One medial meniscus, which is C-shaped, and the lateral meniscus, which is O-shaped. Why this joint has menisci and others don't? Well, the menisci have the most important function to complete the incongruence between the femoral condyles and the hemiplateau. The radius of the femoral condyle is smaller than the radius of the concavity of the tibial plateau. That means that without this menisci, the contact between the femoral condyle and the tibial plateau would have been possible only in one point in the middle. That means that a high pressure would have been applied to this limited central area of the hemiplateau, leading, of course, in time to the destruction of the articular cartilage. By the presence of these menisci, the pressure from the condyles to the plateau is distributed equally on the whole surface of the tibial plateau. So that's very important for the biomechanics of the joint. The mechanism of the knee sprain is usually during sports activities. And here are some possible sports that may lead to sprains. One of them is you see the lateral hit of the knee. Well, this is American football, what you see here, not very popular in Europe, not only in Romania, but we can assimilate maybe this American football with rugby, which, well, the kind of trauma that can be seen is quite similar. Lateral hit at the level of the knee. Other sports, of course, the most popular sport is soccer, which produces trauma at the level of the knee. Uh, the most frequent mechanism was also a lateral hit at the level of the knee of the players by his opponents during the game, especially when the opponent hits with his boot on the lateral aspect of the knee. So also we recognize here a valgus mechanism. So these are mainly valgus mechanisms. Or valgus mechanism will damage the structures on the medial aspect of the knee. Also, another one will be the forced rotation mechanism. Here is a skiing mechanism where one ski during uh, coming down on the slope, yeah, the tip of one ski grabs an obstacle and forces the knee in external rotation. This time also we have a mechanism of sprain. And all the other sports that suppose jumping, landing, or sudden changing in the direction of the body during the sport are susceptible of leading to sprains of the knee. Like I said, if the force is applied on the lateral aspect of the knee, then the damage will go to the medial aspect of the knee of different degrees. Here we have a lesion of the medial collateral ligament which was detached from its proximal attachment. Here, the same thing, but the detachment was from its distal attachment. Or, that's very rare, in fact, we may get a lesion in the middle of the ligament in the fiber tissue. And the extreme right image shows us, in fact, the most often situation when, if the trauma continues, besides the complete torn of the medial collateral ligament, we may have a lesion of the medial meniscus and even a lesion of the anterior cruciate ligament. This, this is called a triad lesion, meaning that during this mechanism we have three anatomical landmarks that are torn with the occasion of the trauma. These sprains at the level of the knee will, of course, follow the same classification system we have already mentioned, and I don't want to repeat it before, in the three types of sprains. Of course, now comes the diagnosis. Exactly like in ankle, the diagnosis will be done mainly by physical examination. First of all, we have to, the symptoms will be the same like in the ankle. Pain at the level of the knee, usually on one aspect of the knee, medial or lateral, depending the side that was damaged during the trauma. and the physical disability, meaning the limitation in knee motion, first of all, and then some instability or even impossibility of weight bearing on that limb. So these are the symptoms. A simple inspection, we may see that the ankle on the injured side is swelled, meaning bigger than the other one. The knee, like ankle also, is a superficial joint, so is located under the skin. So it can be easily inspected, its shape can be easily inspected, especially if inside the knee will have an accumulation of a liquid. So in this situation, the joint becomes from virtual, like we used to say at physiology, in real. So we have an accumulation of liquid inside the knee. So we have a swelled knee, which is bigger in volume than the other one. We can even detect this accumulation of liquid by the patellar shock. So we can, with our two hands, we can palpate the knee and press the patella downwards. The patella will sink in the liquid which is inside the knee, and then we release the pressure over the patella. It will come back by floating on the liquid and give us the exact feeling of a floating of the patella on a liquid which is inside the knee. It's a maneuver of the patellar shock. Of course, we cannot know what kind of liquid we have inside. We may have yellowish liquid. This is called hydarthrosis. Or we may have blood inside the knee, which is named hemarthrosis. The differential diagnosis between these two types of inside joint liquid can be done only by knee aspiration. So there is no other non-invasive method that may make a difference between those two. Usually, the hemarthrosis is a sign of an intra-articular complete ligament lesion. We'll see further on a lesion of the cruciate ligaments, when hydarthrosis is mainly a sign of a meniscal lesion. Okay, after that, we need to put the knee in some special positions in order to test its stability. First of all, like you can see here, with the patient supine, we grab with one hand the leg and with the other hand the thigh, the distal third of the thigh of the patient, and we try to put the knee in a forced valgus position. If this valgus position is possible, it means we have the lesion of the medial collateral ligament. The same thing like happens on the medial side of the knee is possible on the lateral side of the knee. Of course, if the trauma is reversed. Here we see instead of forced external rotation of the knee, we may have internal rotation of the knee, and instead of forced valgus position, we may have forced varus position. This time, the lesions, like I said, will be on the lateral aspect. And we may have a lesion of the lateral collateral ligament in the middle of the ligament substance, like here, or more often, the ligament will detach a bone plug from the level of the fibular head, I mean, in the place where the insertion, the distal insertion of the ligament is attached. Well, this detachment of a bone fragment is quite favorable in terms of healing, because what we need to do is to reattach this fragment using a screw, so in fact by osteosynthesis, which will provide a better biological healing instead of attaching a ligament to a bone, because there are two different tissues that may heal one to another. And I remind you again about the common fibular nerve, which passes very close in an intimate relationship with the neck of the fibula, and which can be damaged during these sprains, during this elongation mechanism at the level of the lateral aspect of the knee. I don't insist about that nerve, I have already mentioned about it. Of course, here the same maneuvers will be done, but in the opposite side, meaning that this time we don't test the forced valgus position, but we test the forced varus position to see if we have abnormal mobility at the level of the knee. Always, this maneuver must be done after we have checked the counterlateral knee, which is supposed to be normal. Because, like I said, some persons have physiological laxity of the joints. So we have to be aware of this before starting our examination. In knee also, like in ankle, we may perform x-rays in forced position. And we can take a front view x-ray with the knee in a forced valgus position, and we may see that the joint opens at its medial aspect. We can even measure the angle of this opening in order to, let's say, make an objective idea about the degree of the sprain. Of course, this is, you'll see this is done also by using the modular device, no more this hands of the examiner that will be kept in, in the way of the x-rays. Which is the treatment of these collateral ligaments? Well, if we have an isolated lesion of the medial collateral ligament, then the treatment is conservative. That is the conclusion that was brought up after a very large number of persons study done in the US about the surgical treatment and the conservative treatment. I mean, the comparison between these two treatments in patients with isolated complete lesion of the medial collateral ligament. And the finding was that the long-term result was the same. So in other words, there is no need to operate on patients with isolated lesions of a medial collateral ligament. We will immobilize the knee in a cast like this one, you can see here, or in an orthesis, a fixed orthesis like this one, for about 4 to 6 weeks, in order to allow for the medial collateral ligament to heal. The attitude will be different if, in addition to the lesion of the medial collateral ligament, we have also other lesions. Like I've mentioned the triad, for example, so lesion of the meniscus or of the cruciate ligament or of the posterior capsule or whatever other soft tissues will be around the knee. If those lesions must be operated, then we are obliged to operate the medial collateral ligament too. Because, like I said, The conservative treatment is valid only in isolated lesions of the medial collateral ligament. And here are some possible methods of fixation of medial collateral ligament. We may use these staples at the at the proximal insertion of the ligament, or we can use a screw with a special washer, which may also keep the ligament in, reattach the ligament in place, or we may use a suture with non-absorbable sutures. All of them, of course, must be followed by the immobilization of the knee in a cast or an orthesis. Same thing can be done on the lateral aspect of the knee. So here you have figured that situation when instead of suturing the ligament, we perform the osteosynthesis by reattaching that bone plug to its place by using a screw, for example. In other situations, we need to suture the ligament by end-to-end non-absorbable suture. All of them followed by immobilization. Well, finally, we have to talk about the anterior cruciate ligament, which is in fact the most discussed and the most challenging problem of the knee sprains. The anterior cruciate ligament may be torn in different situations, like for example, in hyperextension of the knee. In forced hyperextension of the knee, the ligament will be torn because it will come into contact, it will be impinged by the anterior rim of the intercondylary notch. So this is one situation. Another one is that in, of course, during soccer. Yeah, that's the most popular in Europe. In all the other situations, in all the other sports that I have already mentioned, we may get the same result. The association of anterior cruciate ligament lesion together with other soft tissues around, or only isolated lesions. Diagnosis will be also based on the physical examination. Besides the examinations that we have already done and have explained them before, there are some special maneuvers designated for the anterior cruciate ligament. The most valuable one is the so-called Lachman test. Lachman test, which means that the examiner grabs with one hand the thigh and with the other hand the proximal leg and tries to displace the leg anteriorly. In this situation, you see, if this movement is possible, then we say that we have an anterior drawer positive test. In fact, we call this the Lachman positive test, which is a very valuable sign for the isolated lesions of the anterior cruciate ligament. Other tests, it's very important to remind you that this test is done with the knee in a 10 to 15 degrees flexion. So in other words, the knee will be in a slight flexion during this test. In opposition with the next test, which is done with the knee in a 90 degrees flexion position, when the examiner grabs with both hands the proximal leg and pulls the leg towards anteriorly in order to see if this movement is possible. Also, you can do also the opposite movement by pushing the leg into the posterior position in order to see if we have a lesion of the posterior cruciate ligament. So the anterior drawer sign is shows the lesion of the anterior cruciate ligament. The posterior drawer sign shows the lesion of the posterior cruciate ligament. Here is the posterior drawer sign performed by the physician. The same thing can be done here by taking X-rays in forced position. Again, we have our modular device for putting the knee joints, generally speaking, in forced position. And we can take lateral view X-rays in order to make objective the anterior drawer. We can measure a distance between the posterior rim of the femoral condyles and the posterior rim of the tibia in millimeters, which can quantify the degree of laxity. Well, this test is not done anymore in our days as long as we have the MRI. You know, in the last 10 or 15 years, probably, I don't remember exactly, we have the MRI, which is a very important exploration in order to assess the soft tissues around the knee. Of course, it's very important test, this MRI. Here you have an example of a complete anterior cruciate lesion done by MRI. We can see the complete interruption of the ligament. All we have to do is to correctly interpret these MRIs. I mean, not to limit our diagnosis to MRIs, because MRIs must be always integrated with the physical examination. There is a tendency in our days of diminishing the physical examination and considering the MRIs as being the golden standard for the diagnosis, which is not correct, completely not correct. We must always associate the physical examination with the MRI. Okay, what's the treatment of these anterior cruciate ligament lesions? That depends on the status of the patient. A patient over the age of 50, which has not a very important physical activity, maybe he plays tennis or for pleasure, or goes to tennis maybe once a week also for pleasure at a low level, these must not be operated from the very beginning. They must be at the beginning sent to the kinetotherapist, who will start a physical rehabilitation program designated to develop the muscles of the thigh, especially the quadriceps extensor mechanism, which is a very important stabilization factor of the knee in standing, I mean in full extension of the knee. And by strengthening this muscle and the extensor mechanism, probably 50% of these patients will be satisfied with the stability of their knee. And I mean for everyday activities. When they go for their pleasure sports activities, they may use this kind of orthesis, which will augment the stability of the knee, and so they can do everything they done before the trauma. In professional athletes, this is not possible. These persons and those where the kinetotherapy treatment didn't succeed must go to surgery. Surgery in this situation consists in replacement of the anterior cruciate ligament by using grafts from the neighborhood. Pay attention, suture of the ligament is no more possible. Even in acute trauma, suture of the ligament, anterior cruciate ligament, is not a method of choice, because also very exhaustive studies have been done in the US showing the failure of these sutures in patient after trauma. So forget about suture of the anterior cruciate ligament. The only way of restoring its function would be reconstruction. And here is an example. We can use the middle third of the patellar tendon together with two bone plugs attached to it, one from the patella and the other one from the anterior tuberosity. So finally, we have a, a graft which is called bone tendon bone because it's composed of this type of tissues. This graft is introduced in the knee through two tunnels, one of them in the medial hemiplateau and the other one in the lateral condyle, so that the ending of the tunnels inside the knee must be exactly on the place of the natural attachment of the natural ligament. So that means that when we introduce the graft in the knee, we will replace it exactly in the place, the tendinous part, of course, the place of the natural ligament. And we fix these bone plugs in the tunnels by using this interference screw, which is an absorbable screw, which is introduced forcingly between the wall of the tunnel and the bone graft. Of course, this method is probably recently the aspect of the thigh. We harvest these tendons, fold them in two or three or four in order, depends on the length of the tendons and of the size of the patient, of course. So you obtain a tendinous graft, which is introduced by the same manner through the same tunnels in the knee and fixed by using also absorbable devices. It's done, of course, by arthroscopy. Here is an X-ray after such a reconstruction. This is a very old X-ray. This is a reconstruction I've done probably 20 years ago. But I've chosen it because at that time we are using normal screws, metal screws, because if I would present you a recent one with absorbable screws, you won't see them. They are not detectable by X-rays. I present this in order to see the direction and the position of that interference metallic screws that using at that time in order to understand the principle. So the principle is to fix the graft in the tunnel by introducing these screws. Of course, after surgery, the patient must undergo a long period of physical rehabilitation, which may be prolonged from 6 to 9 months until he will be allowed to return to its normal physical activity, especially to return to its normal sports activity. Okay, we are done today. At
Thank
11
you.
o'clock, at 11 o'clock you meet, I don't know who, for the practical demonstration, yeah?
Yes, thank you.
Okay,
Have a
you're
nice
welcome.
day.